Stand up right now if you can. Stand the way you normally stand when nobody is watching. Feet somewhere comfortable. Weight wherever it lands. The posture your body defaults to when you stop thinking about it. Now look down at your torso. You are looking at the muscles that fitness culture has told you control your posture. Rectus abdominis, the front wall. Erector spinae, the columns running up either side of your spine. Obliques at the sides. These are the muscles that appear in anatomy diagrams when you search core. They are the muscles that personal trainers point to. They are the muscles that respond to crunches and planks and deadlifts. None of them are primarily responsible for your posture. The muscle controlling whether your spine is stable right now sits roughly 1 to 2 centimeters from the surface of your vertebrae, on both sides, running the full length of your lumbar spine in short segmental bundles. Each bundle spans only 1 to 3 vertebral levels. Each one is too small to see, too deep to feel, and too close to the bone to produce the kind of bulk that would make it visible in a mirror. Its name is the multifidus. And alongside it, wrapping around your entire trunk like a corset beneath all the other layers, is the transverse abdominis, a horizontal sheet of muscle whose fibers run perpendicular to every other abdominal muscle, whose contraction pulls the abdominal wall inward rather than shortening the trunk, and whose job has nothing to do with producing movement and everything to do with preventing unwanted movement. Together, these two structures form what spinal researchers call the local stabilizer system. They are anatomically positioned to do one thing that no surface muscle can do: control the stiffness and position of individual spinal segments, one vertebra at a time, before any load arrives. Paul Hodges at the University of Queensland has spent over 25 years studying these muscles with fine wire electromyography, electrodes placed directly into the muscle tissue to measure when they fire and how much. His data, published across dozens of peer-reviewed papers, established something that overturned the standard model of how the spine works. The multifidus does not respond to load, it anticipates it. That distinction is the entire story. If you're enjoying this story so far, don't forget to hit the like button and subscribe. Drop a comment telling me where in the world you're watching from. I love hearing from you. Most people think of posture as a position. The angle of the head, the curve of the lower back, whether the shoulders are rounded or retracted. Physiotherapists have historically taught posture this way, as a static alignment to be corrected by reminding patients to sit up straight or pull their shoulders back. This model is wrong, not partially wrong, mechanically wrong. Your spine is 33 vertebrae stacked on top of each other, separated by discs, connected by ligaments and muscles, and inherently unstable at every segment. If you removed all the muscular support from a human lumbar spine and applied a compression load representing normal body weight, the structure would buckle at approximately 90 newtons of force. A healthy adult lumbar spine transmits 10 to 20 times that force during ordinary standing. The only reason it doesn't buckle is continuous, active, millisecond to millisecond muscular control of every segment simultaneously. Posture is not a position. Posture is a dynamic control problem being solved continuously by the nervous system, and the primary solution runs through the deep local stabilizers, the multifidus and transverse abdominis, which are the only muscles with the anatomical positioning to control individual vertebral segments rather than gross spinal movement. The surface muscles, the erectors, the rectus abdominis, the large torso movers, are too far from the spine and too large in their action to perform segmental control. When they contract, they move the whole spine or the whole trunk as a unit. They cannot micro-adjust the position of L3 relative to L4, while L5 does something different simultaneously. The multifidus can. Its short segmental bundles are positioned to do exactly that, and nothing else. Manohar Punjabi at Yale spent decades formalizing this distinction in what he called the spinal stability model, published in the European Spine Journal in 1992 and still cited in spinal research today. He described 3 subsystems: the passive subsystem, bones and ligaments, the active subsystem, muscles, and the neural control subsystem, the nervous system coordinating the other 2. His central argument was that spinal stability requires all three to work together, and that failure in the active subsystem, specifically the deep local stabilizers, could not be compensated by any amount of passive or surface muscle activity. The spine needs the right muscles, not just strong muscles. Lift your right arm. Just pick it up, casually, the way you would reach for something on a table. That movement, as simple as it seems, required your trunk to stabilize before your arm moved. The force of your arm accelerating upward would have created a destabilizing load on your spine if nothing anticipated it. Your trunk had to be stiff before the arm moved, or you would have swayed backward with every reach. Here is what Hodges found when he measured this with EMG across multiple muscle groups simultaneously. The transverse abdominis activated 30 to 40 milliseconds before the deltoid, the primary shoulder muscle moving the arm. The multifidus activated a comparable interval ahead of limb movement in every direction tested: arm raises, leg raises, perturbations, external loads. 30 to 40 milliseconds. That is faster than a voluntary response. You cannot consciously contract a muscle that quickly in response to a stimulus. The feed-forward activation is pre-programmed. The nervous system sends a preparatory signal to the deep stabilizers ahead of every intentional limb movement, stiffening the spine before the destabilizing force arrives. This is called anticipatory postural adjustment, and in healthy adults with no history of back pain, it runs automatically and continuously, without any conscious involvement. The spine is pre-stiffened for every movement before the movement happens. The system anticipates. It does not react. The critical finding that Hodges published in Spine in 1996 and replicated in multiple subsequent studies across different populations is that this feed-forward timing is specifically disrupted in people with chronic low back pain, not weakened, not slowed. The sequencing is reversed. In people with a history of back pain, the transverse abdominis activates after the prime movers rather than before them. The stabilizers respond to the movement instead of preparing for it. The spine moves unprotected. Every arm raise, every step, every reach exposes the individual vertebral segments to the destabilizing forces that the deep system was supposed to prevent. The surface muscles then work harder to compensate, but they are the wrong tool for the job. Large, far from the vertebrae, and producing global movement rather than segmental control. The result is a spine that functions adequately for years, while the cumulative microtrauma accumulates in the discs, facet joints, and ligaments. The failure was not the surface muscles being too weak. The failure was the deep system losing its timing. That timing is what posture actually depends on. The first time someone has a significant episode of low back pain, something happens to the multifidus that most clinicians have historically overlooked. Within 24 hours of acute back pain onset, the multifidus on the side of the pain begins to atrophy, not from disuse, from a neural inhibition mechanism that the nervous system initiates in response to pain and joint inflammation. The pathway runs through articular afferents, sensory receptors in the spinal joints that, when stimulated by inflammation, send inhibitory signals to the motor neurons supplying the local muscles. The nervous system, perceiving joint damage, reduces the motor drive to the muscles immediately surrounding the damaged segment. The working hypothesis is that this prevents further movement at the injured site during acute healing. Whether that protective rationale is accurate is debated. What is not debated is the outcome. Hydes, Richardson, and Jull published the imaging data in Spine in 1994 and in Clinical Journal of Pain in 1996. Using ultrasound imaging, they documented multifidus atrophy on the ipsilateral side within days of acute low back pain onset. The atrophy was segmental, affecting the bundles adjacent to the painful level, while bundles at other levels remained relatively intact. The more significant finding came from the follow-up work. Patients whose acute back pain resolved completely with standard treatment, rest, anti-inflammatories, manual therapy, showed persistent multifidus atrophy at the affected segment 10 weeks later, regardless of symptom resolution. The pain had gone. The inhibition had not been reversed. The muscle had not recovered. In the absence of specific retraining, the multifidus does not spontaneously restore its cross-sectional area or its feed-forward activation timing, even when the pain that triggered the inhibition has fully resolved. The symptom and the dysfunction have different natural histories. Pain resolves. The neural inhibition of the local stabilizers persists. This is the mechanism behind recurrent low back pain. The most consistent finding in epidemiological back pain research is that the strongest predictor of future back pain episodes is previous back pain. The reason is not psychological. The reason is that after the first episode, the local stabilizer system remains inhibited, the spine continues to move with inadequate segmental control, and the tissues continue to accumulate microtrauma at the same segment until the next pain episode triggers. Each episode reinforces the inhibition. Over years, the multifidus at the affected levels undergoes fatty infiltration. The contractile muscle tissue is gradually replaced by fat, a process visible on MRI and documented extensively by Parkola, Rytokowski, and Cormano in their imaging studies of chronic low back pain populations. The muscle does not just get weak, it gets replaced, and the spine it was supposed to protect continues to be controlled by surface muscles compensating for a job they were never designed to do. If you're hooked on this story, make sure to subscribe and turn on notifications so you never miss an upload. Your support means everything, and helps me bring you more emotional stories like this one. The lumbar spine is not an isolated structure. It is the base of a kinetic chain that extends through the thoracic spine, the rib cage, the shoulder girdle, the cervical spine, and the skull. When the deep segmental control of the lumbar spine fails, every structure above it adjusts its position and its muscular strategy to maintain upright posture and the ability to move. These adjustments are not random. They follow predictable mechanical patterns that have been documented consistently across clinical populations with chronic low back pain. The pelvis anteriorly tilts. When the deep abdominal stabilizers, the transverse abdominis in particular, lose their resting tone, the anterior abdominal wall no longer provides the anterior tension that keeps the pelvis in a neutral position. The hip flexors, which attach to the lumbar vertebrae and the anterior pelvis, are now unopposed. They pull the anterior pelvis downward. The lumbar curve increases. The lower back goes into exaggerated extension. The thoracic spine compensates by increasing its kyphosis. The forward curve of the mid-back increases to keep the center of mass over the base of support. The head migrates forward. For every 2.5 centimeters, the head moves anterior to its ideal position over the spine. The effective load on the cervical extensors increases by approximately 4.5 kilograms. Kenneth Hansraj published this calculation in Surgical Technology International in 2014, and while the exact numbers have been discussed in subsequent literature, the directional relationship is not disputed. Forward head posture loads the upper cervical extensors, the suboccipitals, the levator scapulae, the upper trapezius, continuously and disproportionately. These muscles were not designed for sustained isometric loading. They fatigue, develop trigger points, reduce their blood supply through sustained contraction, and generate the chronic neck and upper back tension that has become near universal in populations that spend significant time seated at screens. The shoulder girdle follows, with the thoracic kyphosis increased, and the scapulae pulled forward and downward by the weight of the arms and the tightened pectorals. The rotator cuff muscles must work at a mechanical disadvantage to maintain shoulder joint stability and move the arms overhead. Impingement syndromes, rotator cuff tendinopathy, and shoulder pain are downstream consequences of thoracic posture, which is downstream of lumbar stability, which is downstream of the multifidus and transverse abdominis. The chain runs. Deep lumbar stabilizers fail. Pelvis tilts. Lumbar curve increases. Thoracic curve compensates. Head migrates forward. Neck extensors are chronically overloaded. Shoulder mechanics are compromised. This sequence is not speculative anatomy. Shirley Sahman documented the systematic patterns of muscular length-tension imbalance that follow predictable mechanical logic in her clinical work at Washington University, published in her 2002 textbook on movement impairment syndromes. The surface presentations, neck pain, shoulder impingement, headaches, upper back tension, are the visible symptoms of a stability problem that started much lower and much deeper. Treating the neck without addressing the lumbar foundation is treating the last link in a chain while leaving the broken link intact. The symptoms return. They always return because the mechanical cause was never addressed. Sitting has been blamed for posture deterioration, low back pain, and a range of downstream health consequences with an intensity that suggests it is an aberrant human behavior. It is not. Humans have always sat. The problem is not sitting. The problem is what sitting does to specific muscles when it is sustained for long periods without interruption, and why those muscles matter so much. In sustained sitting, the hip flexors shorten. The gluteal muscles, the primary hip extensors, are placed in a lengthened, low-activity position. The transverse abdominis, without the postural demand of standing and without conscious activation, drops toward minimal resting tone. The multifidus, without the loading demands that upright posture and movement would normally impose, reduces its tonic activity. This is not a catastrophic event from a single long sitting session. It is a cumulative adaptation. Muscles adapt to the demands placed on them. The deep stabilizers are no more exempt from this principle than any other tissue. Sustained periods of low demand, repeated across years, reduce resting muscle tone, reduce cross-sectional area, and, in the case of the multifidus specifically, are associated with fatty infiltration of the contractile tissue. The sitting itself is not the mechanism of injury. The mechanism is the sustained absence of the feed-forward loading demands that keep the deep stabilizers active and properly timed. Upright posture, gait, load-bearing activities, these are the inputs that maintain the local stabilizer system. Remove them for 8 to 10 hours per day across working years, and the system adapts downward. The intervention, then, is not to stop sitting. It is to interrupt prolonged sitting with movement frequently enough that the deep stabilizers receive adequate loading stimulus throughout the day, and to address the specific inhibitions and retraining deficits that have accumulated in the local stabilizer system directly. Bjorn Asa and colleagues at Umeå University in Sweden published data showing that regular brief interruptions to sitting, every 30 minutes, produced measurable improvements in back pain and lumbar muscle function compared to prolonged uninterrupted sitting, even when total sitting time was equivalent. The total duration was not the variable. The interruption frequency was. The implication is practical. Sitting for 30 minutes and then standing and walking for 2 minutes accomplishes more for lumbar stabilizer function than any amount of adjusting chair height or lumbar support placement. Movement is the stimulus. Position is secondary. The multifidus and transverse abdominis cannot be trained the way surface muscles are trained. This is the central practical problem. A bicep curl trains the biceps because the nervous system can voluntarily direct attention to the contraction, feel the muscle working, increase load progressively, and measure fatigue. None of these feedback mechanisms apply to the multifidus. You cannot feel it contract. You cannot isolate it voluntarily with a conventional exercise. And because it operates through a feed-forward system that runs below conscious awareness, simply deciding to activate your core during a deadlift is not addressing the specific neural pathway that keeps the segmental stabilizers firing ahead of movement. Carolyn Richardson and Julie Hydes at the University of Queensland, working alongside Hodges, developed a specific retraining protocol that was validated in a randomized controlled trial published in Science in 1999 and in the Medical Journal of Australia in 2001. The protocol has since been replicated and modified by numerous research groups, and its core principles remain the foundation of evidence-based local stabilizer retraining. The starting point is learning to contract the transverse abdominis in isolation, because it is marginally more accessible to conscious control than the multifidus, and because its contraction through the thoracolumbar fascia creates a co-contraction response in the multifidus via mechanical coupling. The technique is specific. Lying on your back with knees bent, draw the lower abdominal wall gently inward and upward. The movement sometimes described as drawing the navel toward the spine without moving the pelvis or the rib cage, and without bracing or breath holding. The contraction should be gentle. approximately 30% of maximum voluntary effort, held for 10 seconds, repeated 10 times. The reason for the low intensity is critical. The transverse abdominis is a tonic muscle, one designed for sustained low-level activation rather than high-force effort. At high contraction intensities, the global muscles dominate and the local stabilizers are obscured. The target is the opposite, low enough effort that the global muscles stay quiet, and the deep system has to do the work. Ultrasound imaging is the gold standard for confirming the correct contraction is occurring. The transverse abdominis should visibly thicken on ultrasound during the maneuver without oblique contraction. Most clinicians use tactile feedback and careful instruction instead, but the imaging research established what the correct response looks like. After the isolated contraction is consistent and reliable, the next phase is co-contraction with limb movements. The deep draw-in is held while adding arm or leg movements, the same conditions under which the feed-forward system is supposed to operate. The goal is to restore the pattern in which the deep stabilizers are active before and during limb movement, not recruited afterward. Hides, Richardson, and Jull published the one-year follow-up data in Spine in 1996. Patients with acute low back pain randomized to specific local stabilizer retraining had a recurrence rate of approximately 30% over the following year. The control group, who received standard treatment with no specific stabilizer retraining, had a recurrence rate exceeding 80%. The multifidus cross-sectional area recovered fully in the retraining group. It did not recover in the control group. Symptomatic recovery and structural recovery are different outcomes requiring different interventions. Standard care achieved symptom resolution. Specific stabilizer retraining achieved structural resolution. The 80% recurrence rate in the standard care group is the clinical cost of treating the symptom while leaving the underlying muscular inhibition intact. Beyond the specific retraining protocol, certain movement patterns are particularly effective at loading the local stabilizer system once basic activation has been established. Bird dog, simultaneous contraction of opposite arm and leg from quadruped, produces the kind of low-level multi-directional loading that the multifidus was designed for, with sufficient mechanical demand to stimulate adaptation without overwhelming the system with global muscle activation. McGill, at the University of Waterloo, has published extensively on the spine loading characteristics of various exercises, and the bird dog consistently produces high multifidus activation with low spinal compression force, a combination that is difficult to achieve with many conventional exercises. Dead bug, lying supine, controlling lumbar position while moving opposite arm and leg in space, trains the transverse abdominis under the specific condition of resisting extension load while maintaining a neutral spine. The loading pattern mirrors the conditions under which the feed-forward system has to work in daily life. Neither exercise looks impressive, neither will produce visible results in a mirror, neither will be featured on any fitness platform that needs visual proof of work. They target muscles too deep to see, through contraction patterns too subtle to photograph. The spine does not care what is visible. It cares whether the muscles controlling its segmental stability are firing in the right sequence at the right time. The multifidus and transverse abdominis that have been silent and inhibited for years do not recover from a single session of bird dogs. The research suggests a minimum of 8 to 10 weeks of specific training before measurable changes in muscle cross-section and activation timing occur. But the timing changes come first. Before the muscle visibly grows back, the feed-forward pattern begins to restore. The stabilizers start firing slightly earlier relative to limb movement. The spine starts receiving its preparatory stiffness before the load arrives. The compensatory overactivity in the surface muscles begins to reduce as the system it was compensating for starts working again. Posture changes as a consequence of this restoration, not as a target of it. When the deep segmental stabilizers are functioning correctly, the pelvis finds its neutral position because the anterior abdominal tension is restored. The lumbar curve normalizes because the exaggerated extension compensation disappears. The thoracic spine can reduce its compensatory kyphosis. The head migrates back over the shoulders. The neck extensors reduce their chronic load. The The postural correction that people try to achieve by pulling their shoulders back and standing up straight for 30 seconds before returning to their habitual position happens automatically and sustains itself when the deep foundation it depends on is intact. That foundation was always there. It just stopped getting the signal to work. The signal can be restored. The muscle has not forgotten what it is for. The nervous system has just stopped sending the instruction clearly enough, for long enough, for the system to trust that the instruction is permanent. 8 weeks of consistent, specific, deliberate practice tells the nervous system the instruction is permanent. The posture follows. Thank you so much for watching until the end. If you loved this story, check out the other videos on your screen now. I think you'll really enjoy them. And don't forget to subscribe if you haven't already. See you in the next story.